afternoon, everybody. I think we are still in the after lunch syndrome, early phase. Most of the audience are, I hope they are not sleepy. So it is difficult to give talk like this, and also difficult to talk after this eminent speaker, Professor Marco Serini, and interesting lecture. So we'll try to see a new aspect or new topic which was suggested before by Professor Badawi. Autoimmune aspect of some endocrine disease. Today we'll discuss few points regarding this aspect. After introduction, we'll have a list about autoimmune endocrine disease. Then we'll discuss about rheumatic manifestations of some endocrine disease. We will get an example for this one as a thyroid disorder, which is common endocrine disease, and its relation to connective tissue disease. We'll have case presentation, then we'll come to summary and conclusion. So let's start our talk today about autoimmune endocrinopathy. Autoimmune disease represents a breakdown of normal self-tolerance, often at several sites, disrupting the complex balance of immunoregulation maintained by multiple mechanisms within the central and peripheral components of the immune system. Autoimmune disease have been traditionally divided into organ-specific, like that for thyroid disease, pancreas, suprarenal, and non-organ-specific, like rheumatoid and lupus. This depends on whether immune response are directed to an antigen confined to a particular organ, like organ-specific, or to an organ or an antigen that is widely distributed in the body. So it is not surprising nowadays to find that scientific literature is currently filled with studies for two things. Number one, the organ-specific autoantibodies as a marker of autoimmune endocrine disease, like that of thyroid, pancreas, suprarenal. And the second one, which is also important, the association between the organ-specific and non-organ-specific or systemic disease. This is what the target mentioned before by Professor Badawi. If you look here, for example, if there is endocrine conference, you will be talking about autoimmune disease association between diabetes and thyroid, and this is right. And if there is rheumatology conference, from autoimmune point of view, you will be talking about association between lupus and rheumatoid arthritis. And if you look here, as if there is barrier between the rheumatology and the endocrinology, although both of them are autoimmune disease. So we wanted to highlight today that there is overlap and there is no difference between both of them. There is overlap between autoimmune disease and autoimmune endocrine disease, and wanted to see this association and its importance in the decision for management-wise and diagnosis-wise. So this topic explores how far we have traveled in forecasting autoimmune endocrinopathy in both common endocrine disease, like that of thyroid, and in the context of rare but clustering disorders. So let's have a look about the autoimmune disease, autoimmune endocrine disease. Autoimmune affect endocrine disease in two ways. As you see here, it may affect one endocrine gland only, starting from anterior pituitary, it can cause hypopituitarism, even posterior pituitary. Thyroid can cause Hashimoto's or Graves' disease. If you look here also, hypoparathyroidism, it affects the pancreas, can cause diabetes mellitus. Here, Addison disease for suprarenal. Autoimmune orchitis and autoimmune arthritis also are there. So we don't know why the autoimmune system chooses this gland and not the other. This number one. And why it is one gland or not more, or it is more. So if the autoimmune system affects more than one gland, it is called polyglandular autoimmune syndrome. I'm not going to go for details for this one because there are 4 types. I just want to highlight something, the importance of this one. For example, if the patient is having hypogonadism or primary ovarian failure, they are recommending now to look for polyglandular syndrome, to check for suprarenal, to check for thyroid. So it is very important nowadays the progress for autoimmune endocrine disease. This is 1, 2. I'm not going for details for this one. One important point in our talk today is rheumatic manifestations of some endocrine disease. Why I brought this one? Because patient may come to you and you are thinking about one side and the answer for diagnosis is on the other side. So let's have a look. For example, may patient come with myopathy, carpal tunnel syndrome, muscle weakness, cramps, asymmetrical arthropathy. What gland which can cause these rheumatic manifestations? Anyone who can guess? This is rheumatic manifestations of hypothyroidism. That's why they are recommending hypothyroidism should be included in the differential diagnosis of joint that demonstrate even CBBD crystals on aspiration. This is one side. Another example, patient may come with proximal muscle weakness, and another common and serious manifestations is osteopenia, osteoporosis, nail changes, oncholysis, and clubbing. Usually, all of these are manifestations of Graves' disease. So, another rheumatic manifestations of autoimmune endocrine disease. Patient with Addison disease or suprarenal, you will find painful flexion contraction at hip and knees. This improves with IV fluids and steroids. Also, the patient may have weight loss, myalgia, and fatigue. Another manifestations, we have some talk about diabetes and osteoporosis by Professor Vaz, but I'm just highlighting also the association between rheumatic and autoimmune disease. Like diabetes mellitus, patient may have carpal tunnel syndrome, may have reflex sympathetic dystrophy, may have shoulder pain, also osteoporosis as we discussed, and the rare complications which is diabetic muscle infarction. I will go for another important point, which is association between thyroid disorders in connective tissue disease. Why I bring this one? Thyroid disorder is common endocrine disease. So we wanted to highlight the relation between both of them as a common endocrine disease, because sometimes patient will be coming to you, you are giving him treatment, for example, for thyroid, and patient biochemically is okay. But as you see here, he's asking you, doctor, why I'm not feeling well in spite of treatment? Sometimes we don't want to say this answer to the patient. Maybe before waiting for the autopsy, we can look for the other side of the patient, maybe is having autoimmune disease associated with thyroid disease. The association between thyroid and connective tissue disease and data concerning the presence of anti-nuclear antibodies are reviewed here. Regarding polymyalgia, still the data are conflicting for association. For systemic lupus, the ratio would be 15 to 20. Sjögren syndrome is surprising. The association wide range from 10 to 70%. Rheumatoid arthritis, 30%. Sorry for this. For mixed connective tissue disease, still the data are conflicting. And the scleroderma, they found the association for scleroderma is more common in female than in male. Thank you very much. Then we'll have case presentation to review this association between both of them. An 11 years old pre-pubertal girl, previously healthy, with 1 month history of firm but non-painful goiter. There was no family history of thyroid disease. Laboratory investigation shows hemoglobin 12.3, white blood cells 5.2, 2000, and the antibody for thyroid was high here, significantly high. TSH is high, so it is definitely case of Hashimoto's disease. Okay, so patient was started on thyroxine. 6 months later, alopecia, weight loss were observed. 3 months later, Raynaud's phenomena was present, and she complained of fatigue, myalgia, pain, and swelling in hands and feet. There is no fever, no evidence of cardiac, gastrointestinal, or renal involvement. Lab value was almost the same. Thyroid function was normal. So this is what we are saying. Patient may be biochemically okay, but clinically patient is not feeling well. That's why, in such case, we need to look for the other side for autoimmune disease. And if you look here, further investigations was done for this patient, shows ESR of 70, which was significantly high, rheumatoid factor was negative, but for ANA was significantly high, mainly anti-RNP. So the patient was diagnosed to be mixed Hashimoto's disease and mixed connective tissue disease. She was treated with prednisolone 2 mg per kg per day with very good response. 1 month later, she was clinically well. 6 months later, after her initial presentation and being treated with 0.5 mg per kg of prednisolone on alternate days. She was asymptomatic and anti-RNP antibodies was significantly decreased and ESR also significantly decreased. This is what we are saying, the association between the autoimmune and autoimmune endocrine disease. So let's go to the summary for our talk today and conclusion. Autoimmune disease have been traditionally divided into organ-specific and non-organ-specific. It should be pointed out, however, that this division is artificial, as systemic and organ-specific autoimmune disease overlap and appear to share many common pathogenic mechanisms. It is typical of systemic autoimmune disease that rather than global loss of tolerance, there is selective autoimmune response directed primarily against a specific set of autoantigen. Now, we will come another point regarding the management-wise for autoimmune endocrine disease for the current practice. The current management practice remains, however, to intervene with hormone replacement therapy only at the point of almost complete organ failure, leaving little or no scope for disease modification. This is in contrast to approach in many other autoimmune disorders like autoimmune arthritis. This is very strange. Patients come to you and you have predictor that the gland will be totally destroyed or burned, and yet you are waiting, or we are waiting, until the gland is totally destroyed, and then we give hormone replacement therapy. So these gentlemen have a question. Can we prevent or modify disease progression? This question is very important. Why? Because if we can try to do like this, we can keep healthy gland for the patient, either thyroid or suprarenal, instead of waiting until the gland is totally destroyed and then give hormone replacement therapy. It may be beneficial to the patient to keep healthy gland. And before I finish, I just want to remind you, always have a look through the window between rheumatology and endocrinology, and I'm sure all of you know this one. And then we need to fill the gap between knowing and doing. Thank you very much.